How do you manage skin toxicities with immunotherapy, and can these toxicities be prevented? So skin toxicities with immunotherapy are something that we see fairly commonly, and a lot of people are getting more and more well-versed in the management. Just as sort of an overview, for grade 1 toxicities, I would continue the patient on immunotherapy, and we would start some conservative measures. These would include things like topical steroids, and then lifestyle changes, really simple things that we often forget to remind our patients about. Those would include not taking long hot showers or sitting in hot baths, keeping their nails nice and short so that if they're scratching, they're not breaking the skin, making sure that their skin stays well moisturized, and then good sun safety and avoidance. So, it seems silly to say all those things for our patients, but we have to remember that in a time where they're starting active therapy, there's a lot going on and they can be very overwhelmed. So it's great for us to provide those reminders. For a grade 2 toxicity, I would consider holding a PD-1 inhibitor, but I would probably definitively hold an anti-CTLA-4 drug. At that point, you would be considering starting a systemic steroid at 0.5 to 1 milligram per kilogram. We found that with skin toxicities, we can generally taper the steroid over about 4 weeks' time and not see any rebound phenomenon with that duration of taper. And with a grade 2 toxicity, you're still recommending all of the same things that we discussed for grade 1 in terms of good skin care and sun avoidance. For grade 3, at that point, you would absolutely be holding either an anti-PD-1 antibody or an anti-CTLA-4 antibody. You would want to start probably IV steroids because they're going to have a more rapid systemic result for the patient. At that point, also, you want to be considering the risk for opportunistic infections. A lot of times with a grade 3 or grade 4 rash, there can be skin breakdown, and once you start steroids, you have made the patient more immunosuppressed. So please do keep in mind the risk for opportunistic infections. Consult your dermatology services when this occurs because they will be essential in helping you manage the patient appropriately. You may also need to consider consulting the infectious disease service. The one thing that we should not miss with skin toxicities is any signs or symptoms of Stevens-Johnson syndrome. And for this reason, you always should ask patients about whether there's any oral or anal mucosal involvement and about fevers or other associated symptoms. So generally, skin toxicities can be well managed, especially when identified early, which that's the key for all immune-related adverse events. In terms of prevention, we don't have any known preventative measures. Again, as discussed, it helps patients to practice really good sun safety. Don't be out in the sun during the peak sun hours. Wear sunscreen, wear hats, wear protective clothing. Keep your skin moisturized. Don't take those long hot showers. All the things that we talked about with the grade 1 toxicity to help manage can also help potentially prevent patients from getting into trouble.